Very preterm is less than 32 weeks gestation, moderately preterm is 32 to 34 weeks gestation, and late preterm is 34 to 36 weeks gestation. You won't need to know that, just kind of.
So the 20 to 30.
That put patients in preterm labor are gonna be infections, so those are gonna be, your STIs, your UTI, previous preterm births, multi-fetal pregnancy, smoking, substance use, violence or abuse, lack of prenatal care, uterine abnormalities, and a low pre-pregnancy weight, so they're not taking very good care of themselves or following a healthy diet. So our labs and procedures, so we can do a fetal fibronectin test. So this is obtained swab of vaginal secretions, and it's a protein that's expected during early and late pregnancy. So typically the fetal fibronectin, so the FFN, it's taken between 24 and 34 weeks. So if our patient is in any type of preterm labor, we can use a swab. And if there is present, so if it does come back positive, that lets us know that patient is at risk for delivering a baby within the next couple weeks. So that's a test that we can use, and if they're at risk for preterm labor, or even when we stop their preterm labor, they're still at risk because this test lets us know that they could be having a baby during the next couple weeks. We'll do a vaginal examination, so if you have a patient that comes in, we check her cervix, say she's 30 weeks and she's already 2 centimeters. We're gonna see how often she's contracting, so definitely if she's having painful contractions, then we wanna try and stop those contractions with medication, and we'll go ahead and, we'll go into that in a second. If they're having vaginal discharge, so if they have bloody show or any type of bleeding, that's very questionable, then just let the provider know, especially if they're bleeding profusely from their vagina. As a nurse, you do not check anyone that is bleeding profusely from it. Do a cervical check that are bleeding from their vagina, because you could pose a risk of causing more bleeding. So if there's any type of vaginal bleeding profusely, do not do a cervical exam. Now, bloody show is a little bit different, so those that are familiar with like the mucus plug or anything like that, bloody show is meaning that there may be some cervical dilation going on, so maybe like a light bright red tinged, mucus or blood, which is okay. Now, if they're actively bleeding, that's when you do not check their cervix. We can do cervical cultures. So again, if they're in preterm labor, sometimes we want to, there's no type of infection going on. Chlamydia and gonorrhea are the number one STI that puts patients in preterm labor, especially those that are first time pregnancy and they're in preterm labor at 35 weeks or 36 weeks. We want to know what exactly is going on there, so we can do that. CBC, a urinalysis, and then again, we want to put a baby on the monitor. Yeah.
Is the turbule line, is that a part of that or no?
Yes.
Okay, it's in the slides, turbule line. Slide,
hormone marker.
I'll make it work.
Huh?
To stop contractions, so medications that suppress contractions.
Yeah, it's one of the, like, this is a part of that, right?
Medications to stop them from dilating. So again, they're still gonna be like 2 centimeters, but we can stop them from going into 3 or 4 centimeters, we're gonna get them to triple it. So once we stop, we'll go into medications here in a second because there's a lot of medications. For activity restriction, if we are able to stop the preterm labor, whether it's in, triage or if they get admitted in the hospital for a week and they go home, they may have some modified bed rest with bathroom privileges, or they may be on bed rest, or sometimes, depending on the severity of the case, some providers will do a cerclage at some point. It's not very common just because it poses more risks, but it just depends on what's going on. Again, we encourage the client to rest in left lateral position to increase blood flow, and then we tell them to avoid sexual intercourse just because that could bring on labor. sexual activity. And we want to ensure hydration. So during the summertime, especially, we get a lot of preterm gals that come in that are contracting a lot because they're like, oh, I was at, the state fair, or I was at the lake all weekend and not drinking any water. So dehydration will bring contractions on. So we want them to stay hydrated as much as possible. Channel blocker that's used to suppress contractions. So this is also considered as a tocolytic. So nursing actions, what you will need to know is monitor for headache, flushing, dizziness, and nausea. And these are all related to orthostatic hypotension. So the nifedipine is also lowers blood pressure. So that's why that's why they may have those effects. We want them to slowly change positions from supine to upright, again with that orthostatic hypotension that may have that supine hypotension. They may have a lower blood pressure. And then just maintain adequate hydration to counter that hypotension. Here's our magnesium sulfate. So magnesium sulfate is also a tocolytic that we use for preterm labor to help those smooth muscles to relax. So again, if they have a dilation, so if they come in preterm labor and they're 6 centimeters already, we're not going to put them on MAG. They're going to have this baby. There's no way of preventing this baby from coming and stopping labor. So we did not get it past 6 centimeters. So with magnesium sulfate, if we have a patient that comes in, she's in preterm labor, we get her started on magnesium sulfate. So same thing, we're still going to monitor for the MAG toxicity, because they're going to be on this until either they're not dilating, or we can send them home, or as long as she's not dilating, then she's probably going to stay in the hospital all the way up until baby's delivered. Just depends on exactly what's going on. We want to monitor the client closely, so we want to discontinue it when if they're having any signs of pulmonary edema. So that could be chest pain, if they're having shortness of breath, those respirations less than 12. If they're having audible wheezing or crackles, definitely we want to stop that infusion. Effects, so again, they may have some hot flashes, diaphoresis, burning at the IV site, nausea and vomiting, and that just may be due to the medication itself. So it's just be, you need to know what the level of consciousness is. Sometimes if they are having some nausea and vomiting, you may want to go ahead and get a MAG level. So the magnesium levels that we check, each doctor is different, but typically they'll check the patient's magnesium levels typically every 6 hours. So your therapeutic range, I couldn't really find anything in your ATI or even the textbook to, at least for the range that you guys should look for, especially when it comes to ATI. But typically anything between 4 and 7 is your therapeutic range for magnesium. So you keep your patients between 4 and 7. So it's a little bit higher than, if you're taking care of a med-surg case. 8 or above are going to be your toxicity. So that's going to be MAG toxicity. So if you see that, then you're going to stop the medication right away, let the provider know. And then again, you may have to do calcium gluconate.
What was that?
It's the one ratio. To the very bottom of the molecule.
Develop this until about 34 or 35 weeks as it's developing. So with the surfactant, your normal LS ratio, you'll just need to know what the normal is versus the abnormal. So normal is a 2-to-1 ratio. Abnormal is anything less than 1, but 1-to-1. ratio 2:1, abnormal is 1:1. So if you get that test back and your abnormal, so your LS ratio is 1:1, we're going to get betamethasone because that's letting us know that that baby didn't produce enough of the lecithin surfactant for that lung maturation. So if you see 1:1, we're gonna give betamethasone. If you see 2:1, we're okay. Typically this is done by an amniocentesis or a direct collection from the vaginal fluid. We don't do this when it comes to preterm labor. This is just something to know, especially with UTI, because you may see this you're gonna see it on this exam, and you may see it again on the CMS. But typically, when our patients come in and they're in preterm labor, we get them started on magnesium right away, and we give them a dose of betamethasone, so we don't even look at the LS ratio, unless, that patient's been in the hospital for long periods of time and trying to decide on when we're gonna deliver this preterm baby. But all that you need to know about that ratio is abnormal, you're 1:1, you're gonna give what medication? Betamethasone. Any questions on the ratio?
No.
Premature rupture of membranes and preterm premature rupture of membranes. So we have the PROMs and the PPROM. So the PROM is a spontaneous rupture of amniotic membranes prior to the onset of true labor. So again, this is going to be So this is gonna be before 37 weeks. So before 37 weeks. Your preterm premature rupture of membranes is 20 weeks of gestation prior to 37 weeks. So between 20, that doesn't sound right. That does not sound right. Membranes is anything before 37 weeks, okay? That's gonna be considered premature rupture of membranes. I think I wrote that wrong. So if we have a patient that comes in, she says she's been leaking fluid, she's had a big gush of fluid, she comes in, we test that fluid and it comes back positive for amniotic fluid, we know that that patient has ruptured. So say she's 30 weeks and she is considered a premature rupture of membranes. So now that her membranes are broken, her water is broken, we can't do anything. So once the water is broken, either she's gonna go into active labor, or we don't know how long it's gonna be until baby's here. So risk factors with patients that come in with premature rupture of membranes, once we have that, they get admitted to the hospital right away, or just depending on what their gestational age is. But typically, if you had a patient that came in 30 weeks, water's broken, we'll get her started on antibiotics, because now she's at an increased risk of infection. Typically, we can put them on magnesium to try and prolong baby to stay in there as long as possible. The longer the baby cooks, the better outcomes. So they're just gonna keep a very close eye on baby at this point, and then watching on the amniotic fluid. So when they get the ultrasound, they can look at the amniotic fluid sacs to see about how much amniotic fluid is still left, and hopefully baby is still doing okay. But rupture of membranes, early on, they can have the baby right away, or they can have the baby, 2 weeks later, a week later, a couple days later. It just kind of depends.
Would they stay in the hospital the entire time, or if they go home or
Will be in the hospital, but same thing if they were non-viable. So if you have one that came in premature rupture of membranes at 20 weeks, it's considered non-viable. We want to be able to do anything with that baby. If it's typically viable, each hospital is different. It's either from like 22 to 25 weeks. So anytime before 22 weeks, they're considered non-viable. So they can go home and have them on antibiotics, and we tell the patient to come in and see if she may have the baby at home, or come in when she starts getting an infection, if she feels like she's getting an infection. But we start them on antibiotics right away, viable, so typically like 24 weeks or above, they have a better outcome. But they may not be, again, like I said, they're not gonna be, they may not have this baby right away, they can try and prolong it.
I have a quick question before we move on. So what other,
How did they used to do that though? Just send that down to the lab. If it's positive burning, that means her water's broken and her membranes are broken. Another test, just to be familiar with, especially if you guys are going are you guys doing Presbyterian for OB? So we use an amnisure, so it's just a swab that we swab the vagina if they come in thinking that their water broke. We send this swab down in this little tube, so it's called an amnisure. So they test the amniotic fluid that way. AMNISURE. This won't be on ATI, it's just something to be familiar with if you guys see it when you look. Again, the nursing management depends on gestational duration. So if there's, high risk of infection or there's infection already growing, any kind of fetal or maternal compromise, then the care is gonna be a little bit different. We need to prepare for birth if it's indicated, so, if we've done everything and she still continues to go into labor, she's dilating, we just get ready for a preterm baby. We may have to, again, when they're preterm labor, we still swab them, so you may see them do a speculum exam where they'll swab the cervix, so they'll swab for gonorrhea and chlamydia, they're gonna swab for that group B strep, especially if they're preterm, so we know how to treat this baby if the baby's gonna be higher risk for an infection, which most of the time these preterm babies are gonna have some type of infection going on. We want to limit vaginal exams, so we don't want to introduce organisms while we're doing our cervical exam. So once our patient's ruptured, and these are even with our patients that are in labor whose water's broken, we try not to check them as often because they're more prone to infection. Always want to provide reassurance or reduce anxiety, so always talk with these patients, know kind of what their feelings are. Again, therapeutic communication, use your therapeutic communication for this, so always acknowledge their feelings. We want to assess the vital signs every 2 hours, and if their temperature is 38 or above, we need to notify the provider. And we want to monitor the fetal heart rate and uterine contractions the whole time. So we see, we'll go into the fetal heart strips later on, but if we're seeing, our tracings are really bad, baby's not looking too good, we gotta let the provider know because we may just have to deliver this baby. Encourage hydration, obtain a CBC, and then again, anticipate 7-day course of broad spectrum antibiotics. So typically, we'll give some ampicillin used to treat the infection, especially when they get the chorioamnionitis, so that's just an infection of the amniotic fluid. So those that have been like prolonged ruptured, they're more prone to getting this, which is why we check the temperature every 2 hours. So when you get to the hospital and you're taking care of laboring patients, we're checking their temp every 2 hours after their water's been broken. Betamethasone, again, if we have a positive that is amniotic fluid and her water is broken, we're gonna go ahead, anything before 36, or typically anything before 37, there's still providers that are giving that 36 weeks even, sometimes 36 weeks, those babies are having some respiratory issues. So typically 36 weeks or before, they'll go ahead and give a dose, try and get 2 doses of betamethasone. So as soon as we get that result, we do betamethasone right away, get that first dose in, and then they'll receive their second dose of betamethasone 24 hours later. Again, infections is gonna be a big one with our prolonged ruptured appliance. Other complications could be a placental abruption, which we'll go into that next week. Umbilical cord compression or cord prolapse. So if there's not enough amniotic fluid, that can cause, or if the water breaks, that umbilical cord can come out of the vagina and cause fetal distress. Or there may be some compression on the cord because there's not enough fluid, so baby is just sitting on that cord, and the fluid is typically what helps that baby to kind of move off with the position changes. Again, we want to just watch contractions, hydrate, have their kick count, so again, it just depends on how early gestation this patient is. Refrain from inserting anything in the vagina, abstain from intercourse, avoid tub baths, wipe the perineal area from front to back. And then temperature every 4 hours or every 2 hours, essentially, especially if we know that their water's broken. Any questions? So the only thing you really need to know about the preterm is the beta-methysome, the LS ratio, and the tocolytics are what we use for preterm labor. Any questions on any of that? Okay. Because with ATI, like I said, there's only so many questions ATI can create. So you may see similar questions on the exams. Either they're my exams, just because I take the questions from ATI. But if you do your dynamic quizzes, take advantage of the rationales. So if you get the question wrong, look at every rationale for every answer that's there, because typically in those rationales will be an answer for another question. So I would just, maybe do like 10 dynamic questions a day in maternal newborn, do 20 a day, just to become comfortable. I think there's even exams that you can take on ATI if you look up maternal newborn. You guys should have tests already. I think there's like maternal newborn 1, 2, pre-test, post-test, something like that. That you're able to take, and those are going to be similar questions to what you see on the exam. I got a couple of questions over the weekend with the ATI real life maternal newborn. So these are not a grade. So if you look on your topical outline and you have, it's highlighted the ATI real life RN maternal newborn 2.0, and then, gives you your topic. So this one's preterm labor. You do not have to turn that in. So basically what you just learned about preterm labor, you're going to get a real life scenario. Oh no.
Indomethacin.
Indomethacin, and one more. I think someone said it, I may have missed it. Magnesium sulfate. Now something to kind of remember with magnesium sulfate. So if we have a patient that we're inducing because she has severe preeclampsia, so we have her on magnesium, what do you think's happening now that we put her on magnesium sulfate? It's a tocolytic. What do you think's going to be happening with her labor process? It's going to be prolonged. So now we have to introduce a medication to bring contractions on. So
hold on, why did you administer the magnesium?
For the preeclamptic patients.
But they're in labor already?
No.
Because you're saying to put them in labor.
So we have to give them a medication to bring the contractions for them to start to dilate. So if we think about magnesium sulfate as a tocolytic, so suppressing those muscles, so they're not going to be contracting, because also we use mag as a tocolytic for preterm. Now, if we're inducing them, we start them on magnesium. What do you think, if they've been contracting every 2 minutes, what do you think those contractions are going to do over time? Start to slow down. So now, when we go into labor,
She said they're not working.
we go into the labor process, now we can introduce stuff to induce low pitocin, misoprostol, prostaglandins to get the cervix to change. So typically with patients that are on magnesium that we induce, we have them on pitocin. So now they're just at an increased risk of prolonged labor. You continue. So either if they were already on pitocin in labor, and then we start them on magnesium, or we have them on magnesium and we start them on pitocin, but the magnesium stays on at all times unless they are showing symptoms of toxicity.
So like, would they have came in with this like they're taking this magnesium because they have preeclampsia, or this all just like they came in because they're preeclampsia, you're gonna give them magnesium and now they're in labor?
So the magnesium is just gonna help the seizures.
So
Prevent the seizures?
so think about, labor and delivery.
Because you were saying preeclampsia.
So our patients are in the hospital with preeclampsia, we're inducing them.
So we're gonna put them into labor,
We're gonna
that's all I
put
was
them
wanting
into
to know.
labor.
I was
So,
like, that's all I
if they
wanted to know.
have high blood pressures, or if they have any of those symptoms showing of severe preeclampsia, we're gonna start magnesium and start their induction process anyway.
Okay, that's what I was.
But most of the time with these high-risk patients, we are inducing typically with our severe preeclampsia at 37 weeks. And then, with our gestational diabetic patients at 38 weeks. That's when we're inducing them. So we do not prolong their pregnancy unless they're very adamant of not, they wanna go into natural labor, but then you have to go through the pros and cons the provider does. Because again, with hypertension, that placenta may not be working as well anymore, which is why we induce them earlier. Same thing with gestational diabetes. If, you know, the diabetes is especially out of control and that baby is getting bigger and bigger and bigger, now we're at risk for, you know, complications like a shoulder dystocia, or she will just be in prolonged labor because that baby's so big and baby's just not coming down, she's not dilating. So there's always pros and cons to all that stuff.
Like, it's not even a guessing one.
Yes, so when you run Pitocin and magnesium at the same time, so you're going to have your primary line, so you have your primary, which is typically your, you know, the lactated ringers will always have fluids, okay? So you have your LR. At your first port, you can typically put your Pitocin. And then the magnesium at that second port of the primary line. So when you like Y-side it, so you'll Y-side those medications. Yeah, so all those medications can go with LR.
Because LR just interacts with everything.
Yeah, 399 mental.
Okay, so this is it, so just think of this as your primary tubing. So if I have my patient on magnesium, I'm typically going to, so if I have, you know, on a pump here, I'm gonna put them on this port here right below the pump. So that's where I'm gonna put my mag, and my magnesium's gonna be on a separate pump, so I'll put the primary line, so I'll attach it to the primary line here. And then if I start my Pitocin, then I'm gonna put them on this, the closest to the patient, is how. And the way that you'll see it set up, so you'll see the LR set up, it's usually gonna be your first pump. Your second pump is going to be your Pitocin. Your third pump is gonna be your magnesium, so it's all in order. Always keep your lines straight, just because if this patient, this baby went bad and you're crashing this patient, what happens if all of these, you know, IV lines are all over the place? You've gotta take everything off the pump and we're rushing to the back and pushing this patient back. So make sure your pumps are all labeled, so you wanna put magnesium tags, Pitocin tags, and just make sure that everything is untangled, because you don't know what kind of emergency stuff may happen. You can raise it, all pools are different. Yeah, all three of them are the same height, they're on a separate pump. None of them are gonna be secondary infusions where you have to offset it. Okay? Does that kind of make sense with the IV bags? Okay.
Oh,
Let me go over one more thing, and then you guys can go.
the first one, I was like, oh, what's the difference?
Patient who's a gestational diabetic, she just got diagnosed, and her, she's been diet and exercising, but her levels are still fasting glucose is like 150. What are we gonna start? Insulin. Okay, good to go. So if you guys have any questions, go ahead and email me. We'll go over the last section